Time again, pelvic anatomy. I'm sorry for getting started late, Laura. Thank you for the heads up, and thank you for my team helping me to get the technology right. So beginning of the year, I thought it'd be a good thing to talk about pelvic anatomy. I'm going to try to keep it quick. We probably will eat a little bit into pre-op, post-op because I have 90 slides. So at any rate, let's go ahead and get started. Pelvic anatomy is important for us. Let's see if I can do the click through. Oh, I have to click down here. Oh, this arrow maybe. Okay, I have to click it here. Click. Okay, so objectives. We're going to review basic pelvic anatomy, and we're going to focus on clinically important structures, okay? I think all of us, when we start residency, or even when we're residents, or even when we're attending, you know, it's really important we know anatomy. And so we go back to med school, day one, we could think about picking up that anatomy textbook, kind of going through those drawings and being overwhelmed, okay? I do not want to repeat that today. So just so you know, this talk today is going to be very clinically relevant, and what I want to try to do is put that anatomy in clinical context, so that you see the importance and relevance of it. So it's going to be interactive. So have your thinking caps on, and I'm going to ask for participation. Okay, so why, you know why we have to do anatomy. I mean, we're in the pelvis. We need to know what we're doing to keep our patients safe. How do we study these? You know, anatomy is hard to study. But I do think the best way to make it stick is to repeatedly do it, okay? We did it at the beginning of med school, you do it at the beginning of residency, in your internship. But what I really encourage you to do is a little bit all throughout. Every time you have a procedure, review the anatomy, and you'll be amazed. You know, at the end of your 4 years, or even at the end of your first year, it's all gonna be in there, okay? All right, so let's start with the case. You got a 34-year-old G3, P3. She comes in for her 6-week postpartum visit complaining of a midline bulge that she just noticed after starting a new exercise regimen. On exam, you note a separation of the abdominal muscles in the midline. What muscles have separated? Now, what I want to do for this talk is I kind of put cases like this at the beginning of sections. I'm not going to ask you to answer me now, but maybe kind of keep note to yourself what your answer may be. We'll go through the anatomy, and then at the end, we can kind of review. Alternatively, if you guys want to compete with the people down the road in the other room, we could do that. I don't know how you guys wanted to do it. I would try to do poll everywhere, but I couldn't figure it out. Okay, so let's just do that. Everyone kind of make a note. We'll go through it, and at the end, I'll just ask you guys to chime in, okay? All right, second case. Now you're closing a paramedian incision. My favorite. It extends 3 centimeters above the umbilicus, and we are doing a mass closure with a loop PDS. What tissues are you putting your needle through at the apex? When your senior resident closes the inferior portion of the incision, what tissues are being reapproximated? And what are you bringing together with your subcutaneous tissues? Okay, anatomy, all anatomy. Abdominal wall. So let's talk a little bit about the abdominal wall. You guys have all seen this picture. You know, important things that we want to point out in the different muscles. You've got there your rectus abdominis muscle. And in that picture on the left where the arrow is pointing, it's encased in the rectus sheath. You also have your external abdominal oblique muscles. And then you've got your internal abdominal oblique muscles. Okay? So your 12-pack, 6-pack, pony keg, whatever, those are the rectus in the middle. All right, and then you have this window, right, which is showing you those transverse abdominis muscles. So rectus, external abdominal obliques, transversus abdominis, and then your internal oblique muscles. Okay, then when we start to look at the coverings of the muscles, we've got this external oblique aponeurosis, which is that cut edge, so there, and then your rectus sheath, okay? And that little cut edge, that top one, is your Camper's fascia, right? So when you're making your incision, you go through the sub-Q, maybe or maybe you don't see this little thin kind of layer, that's your Camper's, and then underneath it's your rectus sheath, okay? Arcuate line, let's all remember that. It's about 1/3 of the distance between the umbilicus and the pubic bone, and why is that important? There it is. It's because you have different coverings of the rectus muscle above and below the arcuate line. Okay, so above the arcuate line, oh, sorry, I can't remember where my arrows are. So above the arcuate line, you have an anterior and posterior rectus sheath. Okay, but below the arcuate line, you only have the anterior rectus sheath. Okay, again, these are layers you're going to see when you're closing. Now, obviously, the peritoneum is under that, but in terms of what's around the muscle, above you have 2 layers and below just 1. Okay, so first case, separation of the abdominal muscles in the midline. What muscles are separated? Yeah, your rectus, right? Okay. And then now let's talk about closure. So you're doing a mass closure of that huge incision that your oncologist decided to do for the 30-centimeter mass. And so you are the R1 between the legs. What tissues are you putting your needle through at the apex? Yeah. Mm-hmm. Yep. So you're bringing all those layers together. So you're getting the fascia, so you're getting the anterior rectus sheath, you're going through the muscle, posterior rectus sheath, and then obviously the peritoneum, we like to get the peritoneum at the bottom, okay? So that's above the arcuate line. And then you've finished your part, you've tied it off, and then your senior is putting together their part. And so what's the difference between what you put your needle through and what they're putting your needle through? There's no posterior rectus sheath, right? Sometimes we don't close the peritoneum either because we're so close to the bladder, but that's, you'll see that when you operate. Okay, and then when you do your subcutaneous stitches, to close that subcutaneous tissue, I mean, it looks like fat. Ideally, you want to kind of imagine that you're reapproximating that Camper's fascia. Okay, we don't always see it, but theoretically, that's what we want to be putting our little needle through. Okay, let's just talk a little bit more about incisions because I like to operate and I like talking about operating. So different skin incisions, okay? This also relates to the abdominal wall. So what incision is that? 2 finger breaths above the pubic bone. Fan and steel, exactly, okay? Now what's the difference between a fan and steel and a Maillard? We don't do Maillards that often. Maillards tend to hurt a little bit more. They're kind of almost in the same place. But the difference is the Maillard, so for a fan and steel, you cut the fascia and you separate the fascia from the underlying muscle, right? For a Maillard, you actually leave the fascia, attach the muscle, and you cut the muscle. You cut the muscle. So as opposed to lifting and spreading the muscle, you're actually cutting through the muscle. And when you use a Maillard, it actually, because you're cutting that muscle, you get a bigger space. Because you guys probably know when you do your fan and steel, sometimes when you're separating those muscles, even though they're separated, they still can be holding you down. So, we don't do these that often. I mean, we used to do them, like, when I think about doing them, I think about doing them with radical hysterectomies because we wanted to have a lot of visualization. But again, the difference is you do not separate the muscle from the fascia, and you have to watch out for what structure laterally when you're cutting that muscle. Yeah, the epigastric. Okay, and sometimes you end up taking them and you tie them. Okay, and then when you sew it together, if you reapproximate that fascia, then those muscles come together. But the incision does hurt more, but you see better. Okay. Oh, okay. Which one has a higher risk of bleeding? I just went through that. Sorry. Okay, and then churney. Does anybody know what a churney is? So yeah, so it's the same skin incision. So the churney is something you can do. Say that you started with a fan and steel, and you don't have enough space because that muscle, she's got really good rectus abdominis muscles and you can't quite get the visualization you want. You can turn your fan and steel into a churney by doing what? Exactly. You separate that muscle, the rectus, off of the pubic bone. And then again, that just gives you that extra space. And then at the end, you sew them back together. So sew it back down to, maintain the anatomy. Okay. And that's separating the muscle down, that little red cut. Okay. All right. There's the arcuate line. Just as a reminder about the epigastric, inferior epigastrics, the course of them, they tend to start more laterally and then they move more medially above the arcuate line. Okay. So this is why when we're putting in the robot torts, which some of you people did, I don't know, when I first was thinking about it, it made me a little nervous, right? Because you're like, oh, put a fist. So they ask you to put the trocar in the belly button, put a fist down, put the second one on the other side of your fist, which is literally like this close. And it's not what we're used to, right? Because that's down here, we think of that as being, near where the epigastric is running. But we're going above the arcuate line, so the epigastric is much closer to the umbilicus up there. So at any rate, that was something that I was thinking about, okay? So trocar placement, umbilical cord, we know where that goes, right, in the umbilicus. What's important to realize when you're thinking about creating these ports is you have to think about what's underneath it. Okay, so do you guys know roughly for your kind of average person what structures lie underneath the umbilicus?
Bowel.
Okay, so there's bowel there. Definitely there's bowel there, and there's the bifurcation of the aorta. Okay, so in the skinny people, you really want to be careful because that you're right over the bifurcation of the aorta. Okay, and dude, it has happened. Okay, so you can probably go to YouTube. You can probably see the videos where people get into it. It's better to watch the videos and have it happen to you. So that's why people always ask you to elevate and also to kind of aim, you know, not straight on, but either down into the pelvis or a little bit up. So when you watch the general surgeons, they'll aim up. We kind of tend to aim down, away from it. Okay. Then we have our lateral ports. Okay. And so we know where those go. Oh, wait, what did I do? Okay. So for the lateral ports, the classic teaching is, you know, ASIS, 2 in, 2 up, which puts you about 2/3 of the way between the ASIS and the belly button. Now, you know, Jane and I always harp on you, don't put it there, because if you put it there, it's low. And if it's too low, you cannot operate on your side. Okay? And so we'd ask to put it higher. But this is the way kind of gynecology classically tells you to put it. And the thing that's important about that to realize what's under it is your external iliac vessels. So if you go in that place, just be aware that's where your external iliac vessels are. So that's why we start with the umbilicus, we insufflate the belly, and then we go because, you know, you don't want to be in those vessels either. Okay. The other port we put in is Palmer point, right? And just as a reminder, this is the one we use if we think we have adhesions in the umbilicus, if we need to be further up and out of the pelvis. It's in that mid-clavicular line. You identify your clavicle and you go in that line, and it's 3 centimeters below the costal margin. Okay, and you're usually pretty safe there. I mean, okay. There it is up there. So you do have a little muscle to go through. Okay. Let's shift. Pelvimetry. All right, so this is the little quiz. I'm a ways from obstetrics, and I know that you guys do any like clinical pelvimetry now? Not so much. I mean, you learn about it sort of in the book, and you get tested on it on your creogs, right? But I think it's kind of a lost art. We don't really. I mean, also who can feel in some of our patients? But anyway, why don't you guys take a minute? On the top chart, I have A, B, C, and D, which give you the different measurements. So the transverse diameter of the inlet, the AP diameter of the inlet, the suprapubic arch, and the outlet. Just take a minute and see if you can match the pictures with the numbers. And no one can see your answers, so just take a guess. It's the best way. Just see what you can do, and then you come back and we'll talk about it. You know which one you wish we all wish we had a gynecoid pelvis. That is if we want to have babies. If we don't want to have babies and want to have a certain look, we might want to have a different shaped pelvis, I guess. Depending on your fashion style, I guess. All right. You guys good? The ONC team, always striving for the best. There they are, Team ONC. All right. Okay, so let's talk a little bit about the pelvic bones and the ligaments. Okay, so the bony pelvis, you know, you've got, 4 bones there. The green one is your sacrum, number 1. Then you've got your hip bone or your ilium. You've got your ischium, number 3, which is what you sit on. And then you've got your pubic bone. Okay, so 4 bones. Now, we talk about the pelvic inlet and the pelvic outlet. And the pelvic inlet really is that, you see that kind of dotted red? It's that, you can imagine that being a circle. So that's sort of the inlet to the bony pelvis. It kind of is like a funnel. okay? All right, so when you do pelvimetry, you know, some of the key things that you're trying to measure is how big is the inlet. And so you're gonna kind of measure sort of the transverse, which is that on the right, A to A. And then you're gonna do your anterior posterior of the inlet, which goes sort of from the sacral prominence to that pubic bone. There's all these different lines, because I think back in the day when they used to teach it, you know, there was obstetric conjugate and a diagonal conjugate, and it had to do with where on the sacrum you were going with relation to where on the pubic bone you were going, whether it be the top or the bottom. And theoretically, you should be able to measure that on your VAG exam, okay? Your pelvic outlet is that is the transverse number C between your two kind of the tubercles there on the bottom, C to C, okay? Again, this is sort of a picture from days old, how you would kind of measure or how you get your pelvic inlet. So there it is on the far left, estimating the AP diameter, all the different diagonals. And then the transverse is really, you know, if you can imagine that rim of the pelvis, the distance between. The mid-pelvis, that wasn't on that initial chart, but you really kind of measure that mid-pelvis by looking at the distance between the ischial spines. And then kind of figure out the curvature of that sacrum. And then for your pelvic outlet, you're really, you know, the things you want to look at is, again, the curve of that sacrum. Where's that coccyx? What's that angle like, the subpelvic angle, and then the distance between the intertuberous, whatever diameter. Okay, and then, you know, we have these kind of classically described different pelvis shapes. The gynecoid one, which I think is, we all think is probably best for a baby's head to come through, is almost kind of circular, right? And then you've got your anthropoid up top, which your AP is kind of bigger than your transverse. Your android, which is the opposite, your transverse is wider than your AP. And then the platypoid, which is a real kind of extreme, your transverse is more prominent. So if we go back to this, the measurements on A probably correlate best because it's pretty circular with your gynecoid pelvis, right? And then B is like your android, right? Yeah, exactly. So yeah, the heart one. And I think the difference between, you know, B and C, it has to do with the suprapubic arch, right? So C is your anthropoid, and it's just got that narrow arch, which makes it more heart-shaped. So it's more of a point as opposed to rounded, because it's got that narrow suprapubic arch. And then D is your platypoid pelvis. Okay. Important landmarks. So we can talk about this. So I have covered something up there with the blue. So it's pointing to that little bony prominence. And so does anybody know what that bony prominence is and what that landmark is? Yeah, exactly. And clinically, when, you guys probably don't do this, but there is a procedure where that's important. What obstetric procedure is that? Yeah, your pudendal block. Do you guys do pudendal blocks still? Yeah, I think pudendal blocks are awesome. I used to love those. Yeah, they're great for people who don't have their whatever epidural and everything else.
I do. I love it.
Right? I think they're great. So I'm glad
I give it to all my vaginal cases now going home. Yes, thank you.
Awesome.
I will unmute.
Strong. No, that's perfect. I love it. So yeah, so that is your, come on, click through. Ischial spine, and it's a pudendal. Now, how about that bony landmark up there? Your ACEs, right? And we had talked about that. So when are we looking at ACEs? Yeah, for your port placement, right? It just gives us a bony landmark with which to try. Okay, perfect. All right, and then there's your picture of your pudendal block, but you guys do it, so you know. Okay, perfect. Yeah, I've never done it transperineal. I've always done it trans. Well, I mean, how many have I done? You guys have probably done more than me. But yeah, so trans vag. Okay, good. All right, so we're gonna look at some more pictures, and this is another little self-test, pre-test, okay? And And I'm glad you're on here, Dr. Sit. Okay, what procedure is this? And you can just make a note of it, and we can kind of move on. I love these drawings. This is out of like one of those surgical atlases. They don't even make it.
Hey, Paris, you were there at least a third year. Okay, hint, hint.
Yep. Are we doing a spoiler alert, or am I just?
Oh, no, don't say anything. This is a self-test, and we'll go through them at the end. Okay, the next one. What's this procedure? A ton of stitches, man. There's no uterus. You cannot say hysterectomy because that is obvious. It's all the stitching. Don't say, just kind of put it to yourself. Okay. All right. These are all Dr. Sit type procedures, just so you know. Not my type of procedures. Okay, how about this one?
Spoiler alert, Dr. Arroway just did it last week.
All right, so we're quickly just going to talk a little bit about pelvic ligaments, right? So you have bones and then you have ligaments that kind of get, hold everything together. And they're nice and firm, theoretically. Okay, so you've got your sacrospinous ligament, right? You've got your uterosacral ligament, which is not on this picture, but it's obviously connecting your uterus to the sacrum. You have your anterior longitudinal ligaments, which are kind of going along the spine and down and along the sacrum. Okay, and that's your abdominal sacrocolpopexy. And then Cooper's ligament, right? And that's what you're doing your birch on. Okay, all right. So which one is this? You can shout it out. So I'll give you a hint. It says on the bottom, it's sutured to Cooper's ligament. Birch, right? Birch. Yeah, Cooper's ligament. Yeah. Do you guys do those? Do you do those still, Anita? No? You on? No. Okay. All right.
Domingo just did one.
You did just do a birch, right?
So did it in July.
Okay. Yeah. See, we still do it because it's an open procedure, right? You have to do open. Okay. All right. What procedure is this one? Well, yeah. I mean, it could have been done robotically. It could have been done open.
Yeah, I haven't done this for 2 years ago, so they may have not seen it.
Okay, but theoretically, it's a sacrocolpopexy, right? So
correct.
The vagina is basically, you're basically suspending it to the anterior longitudinal ligaments. Okay. All right, and then this one. Yeah, sacrospinous, right? So it's kind of going, the sacrospinous ligament is right there. Okay. Again, important to know that anatomy. All right. Another case. And this is just we can chat through it. So you got a 42-year-old G3P3, and she comes in with complaints of urinary leakage and cough when she does vigorous exercise. In addition to avoiding diarrhea, you recommend Kegel exercises. What muscles is she working to strengthen? Kegel muscles, says Dr. Kegel. Yeah, so it's your pelvic floor muscles, right? And so this is always sort of this fun three-dimensional thing. So just to remind you, what are the muscles and fascia of the pelvis? So you've got two groups, right? So you've got muscles that connect the pelvis to the lower extremity bones. Okay, so that's your obturator internus and piriformis. And then in terms of your pelvic floor, what are the muscles that fill that cavity? It's your levator ani, which is made up of three muscles: the iliococcygeus, the pubococcygeus, and the puborectalis. In addition to the coccygeus, okay? So the levator ani and the coccygeus together form that pelvic diaphragm, and that's really what is sort of holding everything up. And so when you're doing Kegels, you're thinking about really, let's strengthen those muscles so they provide a stronger support and hammock. I think that's the thing too, when we talk about yoga and they say, or Pilates is the one where they're always saying like, lift your pelvic floor. Right? I don't know anybody does Pilates. Maybe it's just my Pilates tape. Anyway, they're like, imagine lifting your pelvic floor. I'm like, so that's what it is. So you imagine it kind of tightening so that all comes up. This is more detailed than we don't have. This is what you get in textbooks. I'm not going to read that for the sake of time. But again, here's a nice picture, right? Okay. So again, this is looking from below. Okay, and so the important parts of the pelvic floor are your iliococcygeus, your pubococcygeus, and your puborectalis. Okay, and everything kind of makes sense, right? It's the part of the muscle that's near the rectum is the puborectalis, the pubococcygeus is in the middle, and the iliococcygeus is in the front with the iliobone. Okay, so that's your levator ani. That's seeing it from below. Okay, and then when you look above, then you can see there's your ischio, or your coccygeus muscle, which is the posterior part over there. Okay, and again, your levator ani, which we did see from below as well. And so that again is the hammock. The pelvic kind of organs are all going through and around that. So your rectum, your vagina, urethra. Okay. And then there's that white line, that tendinous arch of the levator ani, which is important for those support things. Okay. We're going to switch back to OB now. Okay. So a 23-year-old G1P1 at 41 weeks with chorioamnionitis undergoes a C-section for arrest of descent after 3 hours of pushing. Y'all still let them push for 3 hours? Okay. You can shortly. Okay. All right. So you deliver a healthy male infant. However, the patient has a boggy uterus and profuse bleeding. She's given uterotonics, but she continues to bleed. You call for blood, and she's aggressively resuscitated, but she's still bleeding. So what are some of the things that you can do for the bleeding? I mean, you can go through them in a stepwise fashion. So, anyone? Yep. Yep. So you've done all those things. So now, I want you to do something surgical. Yep, you can do a balloon. That's another thing. Definitely try that. God knows wants to throw a needle in there. But yes, B Lynch. Okay, so that's one of those things. So here's your B Lynch, right? And as you were showing us, you put your stitches through over the other side, and you're just cinching down. You're cinching down on that uterus. And since you're sewing directly into the uterus, you're not worried about vasculature as much. Okay. So that's a pretty safe one of the first things you can try to do. Okay, so B Lynch, the compression suture. Now, say you can't do a B Lynch, so then what's the next thing you can do? What's this one? What stitch is this? You're trying to get around the uterine, but you're going into the uterus. Yeah, so you're doing your O'Leary stitch. Okay, and you guys always know, so you want to do it kind of below your incision, because your incision theoretically is in the lower uterine segment. So you want to get this at the level of the internal os, which sometimes you can't tell where it is if their cervix is open, but that's what you want to shoot for. And the important thing to remember is, you're just in ureter territory. But if you stay close to the uterus, just try to ground around the vessel. Sometimes that can stop the bleeding. So it's a bilateral mass ligation of the ascending branch of the uterine arteries. You place it at the level of the internal os, 2 to 3 centimeters below the level of the uterine incision, and then you do it underneath, right? So the bladder is down underneath the peritoneal reflection, or the flap. And then you need to avoid the ureter. Okay, if that doesn't work, the next thing you can do is you can try to do a hypogastric artery ligation. Okay, I don't know if you guys have ever had to do that, but it's something classically they tell you can do. This is kind of your own self-test. So A, B, and C, where would you put your hypogastric artery ligation? And just self-test. Okay, good. All right, so she keeps bleeding. So your intern comes in and shows you this picture. Right? So helpful. Thank you, intern. Nice skeletonization of the vessels. Yeah, but that's basically what we were just talking about, is a hypogastric artery ligation, right? So the vessels never look like that. It's usually under a pool of blood. But at any rate, very nice dissection there. Okay. And again, here's just showing you, you want to go, basically you want to get the anterior visceral branch of the vessel there so that you don't have You want to watch for the ureter. You're going to tie it. Okay, so you don't feel comfortable attempting this. So you call IR. And they come in and they stop it. They embolize it. And everybody's good. She's all good. She's happy. But then on post-op day 2, she starts complaining of buttock pain. And when you examine her, you note this dusky area on her right buttock. What do you think is the cause of her pain? Self-test. Just think about it. Yeah, usually it's something. Yeah. Okay, let's talk a little bit about pelvic sidewall and vessels. Okay. We're just going to go through the pictures, right? So ovarian arteries and veins, we know they're coming off there. Okay. They go through that ligament we call the infundibular pelvic ligament, or the suspensory ligaments of the ovary. Do you notice how you don't see IP ligament anywhere on this picture labeled? No, you don't. I spent a long time trying to find that stupid name, but it's not on the book. At any rate, ovarian arteries and veins. And then the other things, that we talk about that bring blood to the pelvis, okay? So you've got your aorta, then you've got your common iliac vessels, okay? They begin at the lower end of L4. They follow the pelvic ring laterally, terminate over the sacroiliac joint. And that joint, kind of as they enter the pelvis, it splits into external and internal iliac, right? And then the external iliac, that's where our pelvic lymph nodes are located, right on top of those. You go down and they kind of turn into the deep circumflex and your inferior epigastric. Okay. Your internal iliac vessels are a little bit more complicated, but let's start with what we got here. So we have our common iliac arteries, okay, which are kind of above that pelvic brim. Then you have your external iliacs, okay. And again, that's where we do our lymph node dissection. And then that external iliac, you follow it down, it goes to your inferior epigastric and your deep circumflex artery. For the internal iliac vessels, you've got 3 major trunks. And again, there's always anatomic variation, right? But we like to think of them in general like this. So you've got a posterior trunk, which is parietal, okay? So you have your iliolumbar, your lateral sacrals, and your superior gluteal. And then as you proceed away from the head, away from the heart, you have your anterior trunk, which again has parietal, and it's got your obturator, your internal pudendal, and your inferior gluteal, or gluteal. And then it's your anterior trunk, the visceral, which is the one that has all those vessels that feed the pelvic organs, okay? The umbilical, well, it doesn't really feed an organ, but it's umbilical or, yeah. And then you've got your uterine artery, your vaginal arteries, and your middle rectal coming off that anterior trunk. Okay, so we'll go through these with all the lines. So again, so here's your posterior, okay? It's made up of your iliolumbar, your superior gluteal, and your lateral sacral arteries, okay? That's the most proximal. Oh, okay, wow, I put an arrow for every one of them. Okay. Then you have your anterior parietal vessels, okay? Again, not feeding the pelvic organs. So your inferior gluteal and interior pudendal and your obturator artery, okay? And sometimes we call that the, yeah, okay, obturator artery. Yeah, exactly. And again, there's a lot of variation. So we like to think that, oh, here's this posterior trunk, and that's where all those things come off. And then there's this anterior branch that only feeds the lateral structures, not the pelvic organs. And then there's another anterior that comes and feeds the organs that go this way. But as you know, all these vessels can be really different, and how they branch is different. So the key is kind of looking at where they go. Are they going kind of lateral or posterior? Or are they going medial to the organs, right? Because the ones that we care about, it's that anterior branch of the hypogastric that goes to our organs, right? So, your umbilical artery, your middle rectal, and then your uterine, right? And the uterine is the one we're usually most concerned about, okay? All right. What did I just, was it another arrow? Oh, and the vaginal artery is also part of that. Okay. extending. Yeah. Okay. So hypogastric artery ligation. This is a side view. I know, more confusing, but you see your hypogastric. Your hypogastric is here, right? And so your first branch is going to be all those posterior structures, right? Okay, and then your next branch, see how the vessels are going through the organs. So these are your, so even though it's, I listed anterior, parietal, anterior, visceral, they're going medial. So these are your visceral. So you're the ones that you care about. And then here's the other branch, which is going back there. Okay. So if we go back to talking about our hypogastric artery ligation, where do you want to put it? If we put it at A, is that a good, I mean, if we put it at A, we're definitely going to stop, because what we want to get is that vessel going to the uterus, right? Yeah. So if we get it at A, we're definitely going to stop the blood flow to the uterus. But we also may stop the one going to her, she's going to get sore butt, right? Okay. So we don't want A. And then C is distal, right, to the blood supply to the uterus. So if we put it there, that's really not helping us with hemorrhage. Okay. So we want to do B. Oh, sorry. So that's where we want it. B. Okay. And here's just another really pretty pic. There's so many pretty pictures out there, you guys. Now you can look up online. But you see your external iliac artery, your internal. So when you're doing your hypogastric, the first thing you want to do is find that bifurcation, right? So you find the commons, you're almost up at the brim. You find the bifurcation and then you see what's coming off of it. Your first thing you're going to see, or you may not see coming off it, that goes posterior, you don't want to be in front of that. You want to be distal to that. And so then you'll move down and then it'll be probably you want to put it below that posterior one. Yeah, yeah. Okay, why did she have a sore bottom? Because they probably got the superior gluteal, so they probably put that ligation too proximal. Or not ligation, but the embolization was too proximal. Okay. All right, your first shift on night float, and your patient, G1P0, is taken to the OR for C-section, failure to progress. Oh, wait, hold on a second. This is not what I want. Oh, okay. Oh, no, I do want this. I'm sorry. You make a phalansteal incision, and then what do you do prior to making a low transverse incision on the uterus to protect the bladder? What space are you, this is self-test. What space are you developing? Okay, so now we're moving on to organs and spaces, okay? What are the borders of that space? Oh, ooh, that's harder. The organs we know. Okay, next one. You're doing a vaginal hysterectomy on a 43-year-old G3, P3 for persistent cervical dysplasia. And you're having difficulty entering the peritoneum anteriorly because you did a leap on her. What other approach can you take? What space are you entering for that approach, and what are the borders of that space? Okay. 38-year-old G5P1041 has a stage 1A2 squamous cell cancer and a fibroid uterus. We take her to the operating room for a radical hysterectomy, and the first step after making an incision and packing the bowel is shown to the right. What is the surgeon doing? Where are her fingers? What is she palpating? So anterior is up, posterior is down. Yeah, so you can see, imagine that's like a bladder blade or something, that silver thing at the top of the picture. And the uterus is behind her hand. So she's got her left hand in there, uterus is in the palm, and her fingers are in two places, and she's palpating between her fingers. Okay. Got a 44-year-old G2P2 obese woman with symptomatic fibroids and stress urinary incontinence going to the operating room for hysterectomy. At the time of surgery, you perform the following procedure for her incontinence. What is the procedure? What space are you working in to place the stitches? You guys have probably never seen this one, so. But historically, it's a procedure that you may read about. What are the borders of that space? Okay, 45-year-old G0 undergoes a laparoscopic hysterectomy for complex atypical hyperplasia. At the time of surgery, she's noted to have extensive adhesions and obliterated cul-de-sac. In order to safely remove her uterus and cervix, you lyse adhesions and open this space. What is this space and what are its borders? This is something we tried to do yesterday. We kept trying to get in there. We had a hard time finding that space. No space. Okay. All right, let's talk about the reproductive organs. This is probably the most straightforward. I think you guys all know this stuff, right? So your uterus, your tubes, your ovaries, your broad ligament, your cervix, your vagina. Okay, kind of a nice view of it. Side view. Again, I don't know, interestingly designed. We put all the, whatever. The birth canal is in between, what is it there? The recycling and the waste dump, or the waste dump and the, yeah, waste in the water. Yeah, I don't. Yeah, exactly. Why is it all in the same place? Doesn't make sense. Okay, but it is what it is. Okay, the ligaments and spaces. All right, so here's, and I think this, when you do surgery in the pelvis, I think understanding these spaces is critical. Like we need to know our organs, we need to know the blood supply to our organs, but we want to do, when we want to do kind of less bloody surgery, or we want to do surgery in abnormal anatomy, we want to know these spaces because usually pathology does not get into these spaces. Okay, all right. So no matter how bad it looks inside and around our organs in the peritoneal cavity, if we can get into these spaces, they're almost always pretty clean, and we can identify normal anatomy. Okay, so you've got your, and again, patient's lying down, you've got the bladder up on top, so that's anterior cervix, and then the rectum. You've got all these ligaments and all these spaces. All right, and so here's another kind of drawing again. So your space of Retzius is the most anterior space. It's between the pubic bone and your bladder. Okay. And the space is bordered, obviously, anteriorly by the pubic bone, posteriorly by the bladder, and then you have your anterior bladder pillars on either side, okay? So that's why we say when you develop that space, you really want to stay midline, right? Because if you get lateral, you're going to get in the bladder pillar, and what's in the bladder pillar? Vessels, okay? All right, moving laterally and back, the next space we have is the paravesical space, okay? So that's a space alongside the bladder, between the bladder and, again, your bony pelvis. It's got the anterior bladder pillar anteriorly as a border, and the ligament posteriorly is that cardinal ligament, and then also your posterior bladder pillars, okay? So your superior, I mean your paravesical space. Para, by the vesicle, the bladder, okay? Behind the bladder, between the bladder and the uterus, cervix, vagina, is your vesicouterine space, okay? Bladder's anterior to that, uterus, cervix. That's when you get in that nice filmy stuff, yeah.
How far down are those posterior bladder pillars, and do we actually encounter those during the C-section? Because when we develop that space, sometimes they tend to like, oh, laterally, like, make bigger.
That one, it's going to vary. It's going to vary by person, but you see them. So definitely, you know, when we do a hyst, like you don't, it's going to be, they're there, right? On the, like the, usually you can kind of take the cervix down, but sometimes when you get too lateral, you get bleeding. So that's why we ask just to stay right on them, because see how they're just lateral to where the structures are. So that's why you never want to be clearing the bladder wider than this. Now, when someone's got a big uterus, it all stretches out. So these things push laterally. Those borders don't need to come down for the hyst. They don't need to come down. You don't need to take those down. And so you want to try to avoid it. Yeah. Now, when you have abnormal placentation, And we talk about you get all these crazy vessels going in from the bladder to that. Some of them are in those pillars. Okay. All right. You've got your cardinal ligaments there, which we know, connect the uterus and cervix to the side of the pelvis. And then the next space behind the cardinal ligaments is going to be your pararectal space. Okay, again, borders of that, you've got bony pelvis, you've got the rectum, and you've got the cardinal ligaments anteriorly, and then the posterior rectal pillars posteriorly. Okay, so again, cardinal ligament, posterior rectal pillar. These are your ligaments on the side. How are these spaces clinically important? And they're all labeled over there. So your space of Retzius, you're going to be in there when you're doing a birch. Okay. Your vesico-uterine space, you're going to be in there when you're doing your C-section because that's what you're taking down. Okay. The recto-vaginal space, sometimes with your hysterectomy. So that's the space we open, right, when we're trying to look for the ureter. Right? So we open that space, and your ureter is going to be on that medial leaf above that. Wait, hold on. No, I'm sorry. Rectovaginal. Sorry, rectovaginal is behind. I'm looking at the one below it. Rectovaginal is the one behind the cervix, between the rectum. That's the one you're taking down posteriorly. We don't always take it down, but sometimes when we get in there and I'm like, oh no, we got to drop the rectum because I don't want to sew the rectum into the cuff. That's the space we're taking down behind the cervix. I'm sorry, I misspoke. Pararectal is the one a little down there. Never mind. Sorry, confusing everyone. Anyway. Paravesical space up there is, we open that when we do our lymph node dissection, and our obturator nerve is down in there, okay? Rad his, we're in the pararectal space, because that's the two spaces we put our fingers in, and then when we do this, what are we feeling between our fingers? The pararectal, paravesical, and I'm feeling what's exactly lateral. I have a finger in here, I have a finger in here. And this is the space of the cervix, what's this tissue there? Yeah, but what's the tissue, what do you call it? Yeah, parameter, right? Okay, so we can go back here again. So here, this is your, you're doing your C-section, you're doing your bladder flap, and what space are you in? Vesico-uterine, right? Vesico-uterine. And the borders, we talked about it, right? Uterus, bladder pillars, okay? This is a vag hyst. We can't get in anteriorly. How are we going to get in? Yeah, you're going to get in posteriorly. And so what space is that? Yeah, rectovaginal space, right? So you're in behind it, your rectum, vagina, and then you've got your your uterus sacral ligaments there. And then this we just talked about, right? So if you kind of imagine, again, patient's lying on the table. This is the surgeon's left hand. Anterior finger is in what space? Paravesical space. And then the third finger, the middle finger, is in the pararectal space, right? And between those fingers is the perimetrium. Okay. First step of any radical hysterectomy. Why? Because if we feel tumor in there, we're not doing the hysterectomy. Between the fingers. If there's tumor involvement of the perimetria, it means that it's beyond surgical, like we can't cleanly resect it with a negative margin. And if there is disease there, they're going to end up getting radiation anyway. So better to give them one treatment than to surgerize them and give them radiation.
If you're already in there.
Doesn't matter. We take out lymph nodes, but we don't do the hysterectomy. I mean, you could, but then you're going to increase your morbidity.
Right.
Yeah, and we don't want to do that. So, yeah. Okay. All right, and then this one. Anybody know what this procedure is? Dr. Sitt's still there.
Right.
It's kind of like, but it's not going through Cooper's, right? It's going right into the bone. Yeah, it's going right into the bone. It's a suspension still.
Yeah, no one does it anymore,
We
unfortunately.
don't do it anymore. It's historical. It's an MMK. So
Yeah.
Marchetti crayons. We don't sew into the bone anymore. We don't do it. Anyway, you're in the space of Retzius. Okay, there. well, you get in risk of infection, and I don't know. We've moved away from it.
Osteomyelitis.
Yeah, it's
And it
infection.
doesn't really work.
Yeah, and it doesn't really work. So, yeah. But historical. Clearly, I dug up the old books to show you. Okay. All right. And then, I mean, I'm beating a dead horse, but again, you see how important these spaces are every time you're doing surgery, right? So this is the one with the obliterated cul-de-sac, be it an endometriosis case, be it a horrible cancer case. You can't identify anything. You want to get into this space. What is it between the rectum and the pararectal space? Okay. And usually if you can get in there, then it can be clean, hopefully, theoretically. Okay. All right, sorry, I'm gonna kind of get through this. We're almost done. Are you guys doing okay? All right, 38-year-old G3P0 undergoes a abdominal hysterectomy for symptomatic fibroids. At the time of her surgery, her uterus is notable for multiple fibroids, the largest of which measures 7 centimeters and is located anteriorly near the internal os. Profuse bleeding ensues when taking down the bladder, and the uterus is ultimately removed with the cervix. She does have a bit of an EBL of 3,500 cc's. Post-op day number 1, she's complaining of abdominal pain that isn't really relieved with her pain medication. And on exam, she's noted to have rebound and guarding. Blood pressure is okay. Her pulse is okay. Bedside ultrasound reveals a large volume of free fluid. Stat hematocrit is stable. CT is obtained and notable for contrast in the abdominal cavity. What has happened? We haven't had this yet. We have not had this yet recently. Take it back. Take it back. We had blood. We did not have this. Oh, I guess so. Yeah, so there's some kind of ureteral injury, right? Or potentially bladder injury. But bladder injury you'd know about earlier because she didn't have blood in the folate. But yeah, so probably a ureteral injury. And what's all that contrast in her belly and all that fluid? Pee. Yeah, okay. 32-year-old melliferous woman with chronic pelvic pain is taken to the OR for an enlarging left adnexal mass. At the time of surgery, she's noted to have an endometrioma densely adherent to the pelvic sidewall and the posterior aspect of the uterus. You're planning a left salpingo oophorectomy, but you're worried about the ureter. How are you going to identify the ureter to keep it safe? Okay, real stuff. You guys see this. You're going to see this. You got to have a strategy for it, right? And knowing the anatomy is what's going to enable you to be safe and to keep your patient safe. Okay. All right, let's talk a little bit about the bladder and the ureter. Bladder is right there next to the recreation center and whatever, childbirth center. So you can see right there when you're kind of looking down into the pelvis, that relationship between the bladder and the cervix and where the ureters go. Okay, so the ureters are right in next to all of our organs. Okay. And there's that classic relationship, the water under the bridge, right? So those are the uterine arteries going over your ureters. And it's close. Okay, now this is a normal cervix. What happens when you have a cervical fibroid? What happens when you have a big cervical cancer in there? That cervix gets bigger, and what happens? It gets closer to the ureter. Okay. So that's one of the reasons why, you know, when you're dealing with a cervical cancer, why we do a radical, okay, or other times when we may do a radical. If we don't think we can safely take, because classically when we do our hysterectomies, we take those uterine vessels right as they hug we hug the uterus and cervix right at the internal os. But if that internal os is, you know, pushed out because there's a mass in there or there's something abnormal, we can't get a safe clamp, you know, on the artery that's separate from the uterine. So that's sometimes we'll do a modified radical, right? Which is where we take those blood vessels as they cross the ureter. Here, right? Or we can do a type 3 radical where we're actually getting the vessels out here. And then we know we're not at risk of clamping that thing. Okay? So always remember that. If you have a cervical fibroid, you have a big fibroid, and it seems like things are close, like what happens if you put a ligature right here and it's close? You're going to get a thermal injury to the ureter, and 5 days later, she's going to come back with a double P. So, aware of that relationship. Okay, let's talk a little bit about the ureters. So the green kind of outline the ureters. And that little dotted line indicates an important distinction. So below it is in the pelvis, above it's outside of the pelvis. And what's important for the ureter is that the blood supply to the ureter is different out of the pelvis from in the pelvis, okay? So above the pelvis, that blood supply to the ureter is kind of coming medially to the ureter, and then below it, it's coming laterally. Why is that important? Well, because if we're kind of digging the ureter out of there, and we dig too much on the ureter, we could cut it off from its blood supply. So we always, you'll see when we do these ureterolysis, we always want to leave a little bit of tissue on there, because if we take too much of it off, we're stripping the blood supply. Okay. All right, so gynecologists, we get a bad rap. People in the OR say we're always getting the ureter. And we get the ureter, but it's because it's close to where we are, okay?
Just to clarify,
Yeah.
so you mean the little tiny vessel will go into the ureter, those lateral and medial?
Okay, so bad rap for entering the ureter, but if you look at it, because of the anatomy of the pelvis, we're at high risk. We got 3 places where we can get it, okay? What are the most common sites? Well, we can get it up, I wish I had a pointer, right up here, right? Where we're getting the infundibulopelvic ligament or suspensory ligament of the ovary, okay? So we're doing an oophorectomy, we're trying to get the blood supply, and if we don't know and we're getting it high, I mean, we can clamp right across the IP and at the same time clamp across the ureter. Seen it done. You cut, and then it looks all pretty flowery. You're like, oh, what's that big tube? Well, it's the ureter. Okay, so that's one place. So that's why it's real important when you take that pedicle, you either make sure that you're getting only the part going into the ureter, into the ovary, or that you're pulling it away and that you can see the ureter below it. Okay, the ureter almost never is going into the ovary if the ovary is kind of floating there, right? But if your ovary is stuck to the side wall and you're kind of clamping above the ovary, but it's stuck to the side wall, that's when you're at risk. You put that clamp down there and boom, you've got it, okay? Second place where you can sometimes get it is here out in the cardinal ligament. That doesn't happen as often, but it is coursing through here, okay? Again, you might injure it if something's stuck here, you're trying to peel something off, you might, hurt that ureter. If you're buzzing, say that you've got, I don't know, some big fibroid out here in the kind of the broad ligament, and it's distorting it, and say the ureter's draped over it. I think that's happened before. We did that. Ureter draped over mass. And in the blunt dissection, you can avulse the ureter. And then the third place, also in the cardinal ligament is where you get the uterine. That's the other place. And then the third is where it goes into the bladder, down here. Okay. And we can kink it down here. And so sometimes when we put stitches, right? Like if we're closing the vagina and we're lower than we think we are, or the bladder is closer than we think we are, and we, close it, we can sometimes cinch that ureter in right at where it's going into the bladder. Okay, last thing, lymph nodes, and then I'll let you guys do your pre-op, post-op. 68-year-old G2P2 about to undergo staging surgery for her grade 2 endometrial cancer. You're at the scrub sink, and you're a good chief, and you're reviewing the procedure with your intern. She asked you to describe how the pelvic lymph node dissection is done, and what anatomy are you going to review with her? This, look how pretty that is. So this is the left pelvic sidewall. You've got 2 big, I know it's hard when it's not the patient, right? So I guess the first thing to say is you've got these 2 big vessels there, tubular structures on the, I need to get it. Yeah, here. This is the left side. I'm sorry. This is the patient's right side. I'm lying down. So the patient's, the uterus was over here. Okay. So this is the side wall. Yeah, whatever. You know what I mean. You're looking down on the patient. So it is the patient's left. The uterus was here. Anyway, 2 tubular structures here. This is the psoas muscle is out here. Your retractors out here holding the incision open. And then what is this vessel here? It's white and it's thick. External iliac, yes. And below it is the internally. I mean, external vein. So artery and vein. Ha, I almost got you, right? No, I'm just teasing. I misspoke. Okay, what's this little glistening structure here? Just lateral. It's a nerve. Magenta. Yeah. Okay. All right. This space right in here, I opened it. So that's actually one of the first things I do when I do a pelvic lymph node dissection. I open this space. And again, uterus was here, so my vaginal cuff was probably here. In front of that is the bladder. So what space is this? Yeah, paravesical space. Okay. And then this is the vessel probably going to the bladder. And then what is this silvery structure? I've taken the nodes out already.
Yeah.
It's glistening. Yeah, operator nerve. Right? And so when we do pelvic lymph node dissection, we're basically stripping the lymph nodes that are on top of these vessels and in this space. We don't go below this because there's usually a vein below here. As we get into it, it bleeds. And then anterior, there's this circumflex vein, and that's near the border of our dissection. Deep. This is not as pretty a picture. I think it's just because it's darker. But again, you can see the iliac artery and vein here, right? Your gen fem nerves right there.
This one is child, so it's one.
I don't think so. It just is. It's just a dark picture. Maybe it's a live person when it's darker. Okay, 78, last set, guys. 78-year-old woman undergoing surgery for 2 centimeter squamous cell cancer of the vulva, located just above her clitoris. Her procedure involves lymph node dissection. What nodes are we taking out? Pelvic nodes, aortic nodes, vulva. Groin nodes, right? We're going in the groin, right? I'm not making an abdominal incision to do this, and I'm not doing this laparoscopically, right? I'm going to be taking out the nodes in her groin, okay? And so those are the nodes that are located in this inguinal, or your inguinals, in your inguinal triangle, right? So here's this anatomy, right? And so your inguinal triangle, so you can see the, these are your nodes in your little case, and you get this feedback. Okay, so there's this triangle, this sort of the border that's, I mean, it's the outline of the area you want to intersect. Okay, so they talk about this as the triangle. I don't know, did they ever ask you this stuff on your crayons, whatever? Okay, all right, fine.
That's what you would.
Yeah.
Well, we can talk about it. So anyways, there's a border. So you've got your inguinal ligament, your adductor longus muscle, and your sartorius muscle. Okay, so those are your borders of your femoral triangle. And what you want to do is you want to resect the nodes in that triangle. Okay, and those, see, that's them. So you have the superior ones, okay, which the node bundles are there. So you have your inferior nodes, which are the green down there. You've got the superior medial nodes, which is, that's kind of the money up there. And then you have the superior lateral nodes. Yeah.
What's your approach for this?
So what you usually do is you make an incision kind of just over Cooper's ligament. And so that's your incision. You open this way, and then you kind of lift. You want to keep the fat on the skin, so you lift that up. You go down to that fascia, and then you open that fascia. And then you identify, then you dissect everything out over the vessels. But it's an incision that's, yeah, it's again where you use your tubercle. So you use your tubercle and your ACES, and that's a line, and you go just a little bit below that. Yeah. Yeah. I mean, again, it never looks that pretty, theoretically. Okay, I think I'm done. Good job, guys. All right, so was that helpful? So the anatomy is everywhere, you guys, so just think about it all the time, okay? Sorry, I did get into pre-op post-op, so now you guys can do your pre-op post-op.
Hey, Lisa, I want to say thank you. This is an amazing talk. I really wish that as an intern, I learned anatomy the same way as you, applying the procedures and everything together. And thank you again.
Oh, you're so
Love
nice.
it.
Thank you for being here, because there were all these procedures that I don't always do. So
Yeah, I love this, and I never learned anatomy this way. It was a boring, netter, and the attending just pinned me with all these ureter injury sites, but it never makes sense to me. And now, yeah, 50 years old, I got it. Okay, thank you. Slow learner.